Hi, everyone. Welcome back to another podcast on my YouTube channel. In today's podcast, I will be sharing with you some of the frequently asked questions related to the ACO Realizing Equity, Access, and Community Care or REACH model. Let's get started. What is the ACO Realizing Equity, Access, and Community Care or REACH model? The ACO REACH model is the redesigned version of the Global and Professional Direct Contracting Model or Gpdc model and focuses on promoting health equity and addressing healthcare disparities for underserved communities, continuing the momentum of provider-led organizations participating in risk-based models and protecting beneficiaries and the model with more participant vetting, monitoring, and grading. The ACO REACH model provides tools and resources to empower doctors and other healthcare providers to better coordinate and improve the quality of care they provide for patients in traditional Medicare. This approach affords patients greater individualized attention to their specific healthcare needs while preserving all services and flexibilities beneficiaries enjoy in traditional Medicare. The goal of ACO REACH is to provide beneficiaries with access to enhanced benefits and to increase the availability of high quality, coordinated care, including for people in underserved populations. The ACO REACH model takes all the important lessons learned thus far from the Innovation Center's previous model tests and brings accountable care to Medicare beneficiaries who have previously lacked access in new and exciting ways. Why is CMS making the change from Gpdc to ACO REACH? CMS redesigned and renamed the Gpdc model as the ACO REACH model to better reflect the priorities of the Biden-Harris administration, to highlight changes due to feedback received from participants and stakeholders, and to affirm their commitment to health equity as central to improving the quality of care for all beneficiaries. CMS is committed to making sure that our nation's healthcare system works for everyone and eliminates health disparities. The ACO REACH model is designed to advance this goal by requiring all participants to have a robust health equity plan describing how they will reach underserved populations and applying an adjustment to increase the benchmark for ACOs serving higher populations of underserved beneficiaries, which will be identified using a composite measure that incorporates a combination of the Area Deprivation Index and dual Medicaid status to ensure the benefits of ACOs are available to all Medicare beneficiaries. How will ACO REACH focus on health equity? The ACO REACH model seeks to improve quality of care and health outcomes for traditional Medicare beneficiaries. Research shows that certain underserved communities experience worse health outcomes and lower quality of care than the general population. To improve the quality of care and outcomes for all types of Medicare beneficiaries, the ACO REACH model will test ways to address these health inequities. The ACO REACH model is introducing 5 new policies to promote health equity starting in performance year 2023. The new policies are Health Equity Plan Requirement, Health Equity Benchmark Adjustment, Health Equity Data Collection Requirement, Nurse Practitioner Services Benefit Enhancement, and Health Equity Questions in Application and Scoring for Health Equity Experience. These updates are expected to reduce disparities in health such that those with the greatest needs and least resources receive the care they need. Each of these new policies is discussed in greater detail in the RFA and will apply to all REACH ACOs, including Performance Year 2021 and Performance Year 2022 participants from the Gpdc model interested in continuing in ACO REACH, with the exception of the application questions and scoring. Have other models used health equity plans, and if so, what has CMS learned from them? The Accountable Health Communities or AHC model is the only Innovation Center model so far to require a health equity plan. In the ACO REACH model, each ACO will use a health equity plan to identify underserved communities within its beneficiary population and implement initiatives to measure and reduce health disparities for such populations over the course of the model performance period. CMS continues to learn that while documenting disparities and plan mitigating actions is An important first step, it is critical to track adherence to these plans over time and update them as needed. The Innovation Center will provide ACOs with a template based on the CMS Disparities Impact Statement created by the CMS Office of Minority Health to identify health disparities, define health equity goals, establish a health equity strategy, and a plan for implementing the health equity strategy and monitoring and evaluating progress to advance health equity for underserved communities. Future Innovation Center models will also include features like the requirement of a health equity plan to reduce health disparities and expand the reach of models intended to improve care and outcomes. How are current Gpdc model participants affected by the changes to the Aco Reach model? Current Gpdc participants must maintain a strong compliance record in 2022 and agree to meet all the Aco Reach requirements beginning January 1st of 2023 in order to continue participating in the Aco Reach model. For example, model participants must meet the updated governance standard that participant providers or their designated representatives generally hold at least 75% control of the ACO's governing body, which is an increase from 25% for performance year 2021 and 2022. Alternatively, model participants may elect to leave the model. How are beneficiaries affected by Aco Reach? Beneficiaries with traditional Medicare retain all of their rights, coverage, and benefits, including the freedom to see any Medicare provider. Like previous ACO models, the Aco Reach model prohibits limited networks, prior authorization, or any other means of restricting care. Even if a beneficiary is aligned to a Reach ACO, they always have the freedom to see any Medicare enrolled provider. CMS expects that beneficiaries whose primary care provider is part of a Reach ACO will see and feel improvements in the quality of health care they are getting because of the Aco Reach model. For example, they may receive increased access to telehealth, home visits after leaving the hospital, cost-sharing support to help with co-pays, or other enhanced services and incentives. Moreover, the new health equity provisions are expected to provide greater access for underserved communities, reaching beneficiaries who have not previously received coordinated care. Starting in performance year 2023, CMS is requiring each Reach ACO to have both a Medicare beneficiary and consumer advocate serving on the Reach ACO's governing body who will hold voting rights. The same person is no longer permitted to fill both roles to ensure beneficiary representation in the Reach ACO's governance. In addition, CMS will closely monitor levels of care provided over time and compare care delivery patterns to a reference population to determine if Reach ACOs are stinted on beneficiary care. CMS also will conduct compliance audits throughout the year, investigate beneficiary complaints, and conduct beneficiary experience of care surveys or CAPS annually to measure changes in beneficiary satisfaction. Lastly, CMS will monitor whether beneficiaries aligned to the model are being shifted into or out of Medicare Advantage. If at any time a Medicare beneficiary or their caregiver has concerns about the Aco Reach model, the Innovation Center has a model liaison that is part of the Medicare Beneficiary Ombudsman team in the Offices of Hearings and Inquiries. The model liaison can be reached through 1-800-MEDICARE and will assist in facilitating communications with the Medicare Quality Improvement Organizations or QIOs, the CMS regional offices, and Aco Reach model team to ensure the beneficiaries' concerns are heard. What does this mean for healthcare providers? CMS encourages healthcare providers with a strong track record of direct patient care and those who have had success improving the lives of people in underserved populations to apply to be part of this transformative model. Healthcare providers are taking more responsibility for the care they are giving people with Medicare. In the Aco Reach model, providers are incentivized to provide high-quality, well-coordinated healthcare to Medicare beneficiaries, including those in underserved communities. ACO Reach places a strong emphasis on provider-led organizations participating in the model, including a requirement that participating providers generally hold at least 75% of governing board voting rights. This ensures that the care the beneficiaries will receive is driven by quality first. How do risk-adjusted benchmarks and payments work in the model? Risk adjustment has been a critical component of all ACO-based models dating back to the creation of Medicare ACOs with the ACA. Without the ability to adjust benchmarks and payments based on how sick a given beneficiary is, participants are incentivized only to treat healthy beneficiaries, and the sickest, most vulnerable populations are left out. However, including risk adjustment also introduces potential for overcoding, so it is important to have strong protections against such overcoding. The ACO Reach model improves upon the Gpdc model's approach to risk adjustment, which already offered the strongest risk adjustment protection to date compared to other ACO initiatives and MA by ensuring 100% protection to Medicare against inflated payments. The ACO Reach model takes a twofold approach. First, the model caps the risk score growth of each individual model participant at plus/minus 3% over a 2-year period. This is called the risk score cap. Some fluctuation in risk scores is natural and should be allowed, but the risk score cap ensures that no single participant's risk scores grow too fast, which would be to the detriment of other model participants given the second component. Second, it locks in the average risk score across the entire model from before the model began to ensure that risk scores within the model do not grow faster than risk scores in all of traditional Medicare. This is called the coding intensity factor, or CIF. The CIF essentially creates a zero-sum environment and is the mechanism that provides 100% protection to Medicare against inflated payments. The ACO Reach model improves upon how the risk score cap works in two ways. First, it locks the reference year for the risk score cap so that the capped risk scores of a single model participant are not able to grow greater than 3% every 2 years in the later years of the model. Second, it takes into account how the underlying demographics of a model participant's aligned population change over time when determining whether the risk score hits the risk score cap. Importantly, the CIF remains in effect, so Medicare remains fully protected from risk score upcoding. What is the model timeline? The redesign of the Gpdc model, now called the ACO Reach model, starts on January 1st of 2023 and will span 4 performance years ending on December 31st, 2026. This request for applications, or RFA, is for interested provider-led organizations to apply and begin participation in performance year 2023 with an optional implementation period, or IP, to run from August 1st, 2022 through December 31st, 2022. Who can apply to join the ACO Reach model? The ACO Reach model is designed to attract a range of providers and suppliers operating under a common legal structure, with attention given to advancing primary care as a means to better manage Medicare beneficiaries' health. CMS believes that this model is well suited to provider-led organizations, including those with prior experience participating in the next generation ACO model or the Medicare Shared Savings Program, that are interested in continuing and deepening their participation in Medicare shared risk arrangements. CMS is particularly interested in providers with direct patient care experience and a strong track record serving underserved populations. When can organizations apply to participate in the ACO Reach model? The application period for ACO Reach opens on March 7th of 2022 and closes on April 22nd of 2022 at 11:59 p.m. Eastern Time. CMS is not soliciting letters of intent for performance year 2023 starters. Therefore, submitting a letter of intent is not required to apply in response to this RFA. What changes are being made to the applicant screening process? The RFA for ACO Reach requests additional information on applicants' ownership, leadership, and governing board to gain better visibility into ownership interests and affiliations and information regarding their direct patient care experience as well as experience serving underserved communities. This information will help CMS determine if the applicant's interests align with CMS's vision for a healthcare system that achieves equitable outcomes through high quality, affordable, person centered care. What changes are being made to monitoring and compliance under the model? CMS will strengthen its current set of compliance and monitoring activities to ensure beneficiaries are protected and ACOs are adhering to the requirements of their participation agreement with CMS. These activities will include increased use of data analytics to monitor use of services over time and compare to a reference population to assess changes in beneficiaries' access to care, including stinting on care, assessing annually whether beneficiaries are being shifted into or out of Medicare Advantage, continuation of audits of contracts ACOs have with providers to learn about their downstream arrangements and identify any concerns, examining ACO's risk score growth to identify inappropriate coding behaviors, monitoring for non-compliance with prohibitions against anti-competitive behavior and misuse of beneficiary data, reviewing marketing materials and websites to ensure information on the model is accurate and beneficiaries understand their rights and freedom of choice, and investigating beneficiary complaints and grievances in coordination with 1-800-MEDICARE, the Innovation Center liaison on models in the Office of the Medicare Beneficiary Ombudsman, CMS regional offices, and others as appropriate. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.